I'm just going to get my tech set up here. My roadie called in sick, so it's just me and the one-woman show. All right. I feel the energy, but I don't hear the energy. That's awesome. Can I let you guys in on a little bit of a secret? Today is my birthday. And I've never been in front of this many people on my birthday before, and it would be so great for me if you wouldn't mind, maybe on the count of 3, could everyone say happy birthday? Can we do that on the count of 3? 1, 2, 3.
Fantastic.
Thanks, guys. How'd you know? You know, it's also my anniversary today. My husband, Dave, is here in the audience. He is amazing, and he helped me write and direct this piece, so thank you to Dave. This is a big crowd. I don't think I've been in front of this many people for about 14 years since the Miss California pageant, and this is already going better because I'm not in a swimsuit. And these are much more practical heels. So this morning, I was asked to give a narrative talk. This concept of narrative medicine, this is something that my mentor and friend Mel Herbert and I came up with a couple of years ago, this idea of taking a narrative story and adapting it to a live lecture format. And what I hope to do is mix medical education with the human condition, and to tell a story, but from the patient's experience in their own words. And therefore, the patient becomes the teacher. What I hope is that if you remember the story, you will remember the medicine. And so this morning, I'd like to tell you Jonathan's story. On July 8th, 2016, I received an email from Anna Bex, who you wouldn't know, but I do, because she's the wife of a patient that I took care of named Jonathan Bex. She writes, "Hi, Dr. Mason. I just wanted to let you know that yesterday at 11:20 p.m., John took his last breath. He passed away surrounded with family and love. Jonathan had sickle-cell disease, and because of that, he suffered many downstream effects, including heart failure, which is how he ultimately died. He was 43 years old. That's it, 43. And in the last couple years of his life, he was getting more and more ill. I want to tell you this story, but I'm going to tell it in reverse because I want it to end where many of us begin, which is in the emergency department. 5 days before he died, Jonathan was admitted to the ICU for heart failure and fluid overload, which is a big problem for sickle cell patients because as you diurese them, the sickling actually gets worse. But this time, it was much worse than any other time before because despite intubation and exchange transfusions, he couldn't breathe on his own. And so Anna was faced with the difficult and terrible decision to change to comfort care, knowing that he likely would not survive. 2 months before he died, I had Anna and Jonathan over to my house for an interview. Are you guys okay with using your names, or you can be anonymous?
No, it's fine.
Okay. Can you each tell me your name?
My name is Anna Bex.
My name is Jonathan Bex.
This interview took place in May of 2016, and if you listen carefully, do you hear that? That's Jonathan's oxygen tank. He is supposed to be on 4 liters nasal cannula, but his tank is running low, and his next delivery is late, so he is rationing, and he's only using 2 liters per minute. He is sitting in my living room, a doctor's living room, rationing oxygen. We were there that day to talk about his hospital admission 2 months earlier because that's when I admitted him for what I thought was a sickle cell crisis. And this turned out to be a sentinel event for him, a turning point in his illness, because he got much more ill than what was typical for him. So that's why we were there that day, as we were going to talk about that experience. So Anna and Jonathan, they come over to my house, they're walking up to the front door. Anna, she's smiling, she's warm, kind, attentive. She looks at Jonathan frequently to check in with him and make sure that he's doing okay. At the time of this interview, Anna is finishing up nursing school, and before that, she was a paramedic on an ambulance squad, so this woman is no stranger to hard work. Jonathan, he looks like he used to be really strong, and now he's got some muscle wasting. He's got the nasal cannula around his nose. He's wheeling the oxygen tank behind him as he cautiously comes up the steps to my front door. But he's smiling, and he seems genuinely content to be here. Jonathan is not the physically robust version of himself that he used to be.
I was an EMT, and I was a fireman. I was a fireman for almost 2 years, and then I had to give that up because my body just couldn't do that anymore. And then I was an EMT, and that's how I met my wife.
Now, depending on where you practice, sickle cell disease might be something that you see every single shift, or perhaps you see it much more rarely. It's caused by a genetic mutation that leads to a deformity in the shape of the red blood cells. Blood flow gets impeded, and this leads to ischemia and then further sickling. These are the vaso-occlusive crises of sickle cell disease. They are very painful, and they most commonly affect the legs, the back, and the abdomen. And it's also why the treatment for a pain crisis is pain medication and some gentle hydration. Now, if you don't see sickle cell disease where you practice, then I want you to think about some other chronic, debilitating, and painful illness that you do see. So 2 months before this, that's when I had admitted Jonathan to the hospital. So let's talk about the hospital course. On that day, we were pretty lucky because for once there was a bed available upstairs, and Jonathan pretty quickly went right up.
I went upstairs. They put me on my dilated drip.
The pump.
The pump. Probably 6 hours later, I woke up and there was a team of doctors that surrounded my bed, and they were telling me that they were moving me down to ICU, and that's when I blacked out again.
Jonathan developed acute chest syndrome. Ischemia and sometimes infarction of the lungs can be precipitated by pneumonia, but not always. Patients will typically present with chest pain, shortness of breath, fever, tachypnea, and rales. The chest x-ray, that might show signs of infiltrate or infarction, but early on, that can actually look totally normal. Now, Jonathan had experienced acute chest syndrome in the past, but this time, it was different. Because this time, he and Anna, they couldn't remember any precipitating illness, and the onset this time was really rapid.
And this is not the first time that has happened, that he developed acute chest. This one was early on. Normally, if he develops an acute chest, it's usually 2 or 3 days into the admission. This one just came on like that.
The inpatient team started him on BiPAP, but it wasn't going well. He wasn't oxygenating well, and his pH was going down and down and down. And so Anna consents on his behalf for intubation, but even then, things still got worse.
While that's going on, more lab work comes back while they're getting ready to intubate, and they are telling me he's in DIC.
That's right. on top of heart failure, respiratory failure, and acute chest syndrome, Jonathan also develops disseminated intravascular coagulation, DIC. So they transfuse him with cryoprecipitate and fresh frozen plasma. All in the while, they're in this battle of fluids because the more fluid they give him, this worsens his respiratory status. But they do the transfusion, and then they're able to place a central line, and then they can do an exchange transfusion, where they remove Jonathan's red blood cells by apheresis, and they transfuse him with healthy red blood cells. So at least at that point, there's no more net change in fluid balance. Over the next 5 days, they continue to support him on the ventilator, and then they're able to extubate him, and they transfer him to the floor.
And I was up there for
2
day.
hours.
Yeah, like literally one day. And I was down there and I couldn't breathe again, so I had to go back down to ICU.
Jonathan goes back to the ICU for BiPAP and another exchange transfusion. A few more days go by, and he starts to get better. His labs improve. They're able to transition him from BiPAP to nasal cannula, and they are able to finally discharge him home. Now, like I said, Jonathan had been quite sick before, but this time it was really different. And so because of that, I asked Anna if she thought maybe there was a chance that he wouldn't survive this time.
Yeah, because he had never gone down that far, the rabbit hole. And he has, in 10 years that we've been together, he has never gotten this sick without any provocation. And that's the scariest part, because we both understand that with sickle cell, the lifespan is cut in half. We know that. So every day is to the fullest. You know, whatever we can do today, we do it today. We don't leave it for the next day.
Anna is right. The life expectancy for sickle cell patients, that's in the mid-40s. Can you imagine what that's like to go through life knowing that? That must be so hard for Jonathan. And I think, of course, for Anna too, and the effect on her is different. And so I asked her, what is that like to go through something like this with your spouse?
Yeah, we've heard many and many occasions where they said, that's it, we've done what we can, there's nothing we can do, we can't guarantee you that he's going to be here in the morning. And yet somehow he wakes up like nothing ever happened, lab works come back normal, and they don't know why. It's a roller coaster. It's not fun because he's unfortunately unconscious, unresponsive, and has no recollection, but I do. I'm the one talking to the doctors. I'm the one asking questions and signing consents because he can't. And I'm always scared that I will make the wrong decision. The wrong signature on the wrong line means life and death for him. It's nothing I can take back.
I put my faith in her because I know how hard she works. And I'm just blessed to have her in my life.
I visited Jonathan in the hospital before he got discharged, but my initial interaction with him and Anna was very brief, and it all started in the emergency department, 4 months and 1 week before he died. So let's talk about that. Let's talk about what happened in the ER. What was Jonathan feeling on the day that I saw him and admitted him to the hospital?
Just pain in my shoulders and in my lower back. Basically, when my pain meds stop working, it's like literally like a truck's running into me left and right all the time.
Pain crises are just one of the many complications that we need to be aware of when we treat patients with sickle cell disease in the emergency department. We also need to know they are at increased risk for stroke, pulmonary hypertension, acute chest syndrome, CHF, hepatobiliary disease, renal disease, worsening anemia, and septic arthritis. But for Jonathan's case, I just want to take a minute and focus on pain management. Jonathan is on an extensive pain regimen that he is supposed to escalate at home to try to prevent having to come to the ER. He takes 90 milligrams of extended-release morphine twice a day. And then on top of that, for breakthrough pain, he takes 4 milligrams of Dilaudid every 6 hours. And when that's not working, he's supposed to escalate the dose and take it more frequently. So in total, get this, that's 180 milligrams of morphine and 48 milligrams of Dilaudid a day. And only then, at that point, does he come to see us. So when he comes to the hospital, he basically needs, at a minimum, to be admitted and put on an analgesic pump. Now, here's the tragic part. The very reason that Jonathan comes to the hospital, pain control, is the same thing that Jonathan is afraid to ask for.
His biggest fear is using the pump. So even though he's in extreme pain, he refuses to use the pump half the time, because one time a resident came in and said something about, oh my God, like you used so much of, like you used a lot of your pump. And he felt like, should I have not used that much? So after that, now he's petrified. And he's like, well, I don't want you to think I'm overusing. We don't come to the hospital unless we're at a point of no return. We don't show up, at the slightest tinge of pain. We work a regimen, and a lot of it is in his head.
Maybe some of it is in his head, but you know what? A lot of it is in ours, because there is a stigma with opioids in the emergency department. We are afraid that we're turning patients into heroin addicts, or that our compassion gets exploited by junkies and drug dealers selling pills on the street, or even worse, you see someone like Jonathan, and you think, there he is again. There's that sickle cell patient here for his IV narcotics. But let's remember, the sickle cell patients who use the ED more frequently are also burdened with more severe illness, lower quality of life, and higher mortality. I can only imagine the pain that Jonathan was feeling as he finally agreed to come to the ER, desperate for relief and burdened by fear that he would be judged or undertreated by a jaded provider. It is so important that we start IV opioid pain medication early. That is the recommendation in every single guideline about sickle cell disease. You should reassess their pain frequently, and you can slowly increase the dose. So let's talk about what I did for Jonathan in the ER. What did I do for him? Well, I ordered IV Dilaudid. I got some labs, and I got a chest x-ray. Now, some sickle cell patients for a pain crisis, you might not need labs at all, but Jonathan was different. He had multi-organ involvement of his disease, and so I got labs. I got a CBC, a reticulocyte count, a chemistry panel, and a BNP, and really these all just showed that he was right at his baseline. And then I got a chest x-ray. He had a history of CHF and acute chest syndrome. But the chest x-ray also showed that he was basically at his baseline. Now, I remember where my head was at when I saw Jonathan and Anna in the ER, and I admit it. I thought, sickle cell, pain crisis, Dilaudid, admit, that's easy. And then a couple of days later, I followed up on his chart, and I was shocked to see that he was intubated in the ICU only hours after I saw him. So I messed up. I must have missed something. What did I miss? And that's why I went back to talk to him, because I had to learn from this.
You know, one of the things that I always teach him, that if you don't teach others about what you have, nobody will ever know. And we're thankful for you for giving him a voice. Who else would give him a voice?
I have replayed this interaction in the ER that day over and over in my head, and I think that with what I knew at the time, I don't think that I missed the diagnosis, but I did miss the point, and I see it now, and it changed my practice. Sickle cell disease is a terminal illness, and I don't know why I didn't see it that way, the way that I see metastatic cancer, but that's what it is. It's terminal. Patients like Jonathan can get very sick very fast, and if there is something, really anything, that I can do to alleviate that suffering, that is the type of care that they deserve. So thank you to Jonathan and Anna for teaching me this lesson, and I know that they would thank all of you for listening. Thank you.
Thank you, Jess, and thank you to all of you that sent out comments and sent out questions. A reminder to do that while the presenter is presenting, so Aurelia can collect them all. Also a reminder right now to log on to the website and rate the presenters. Aurelia, what can you share with us? Some comments, some questions.
Actually, it was interesting to see, because at first there was hundreds of birthday wishes, happy birthday again, and then Twitter turned completely quiet because everybody was so caught in your story and your narrative telling, and only to the end of your talk, Twitter started waking up again. And mostly they were recognizing your very powerful narrative presentation and how you can use this to teach in a very impressive way. A point that was discussed is that despite the tech advances, cost pressures do affect all, and which perspective we might have to lower those cost pressures on patients and the financial implications for John and Ella in particular. And they also brought up whether we can make structural advancements like patient advocates or care navigators. I don't know if you have any experience with this.
Well, I think patient advocates are always a good idea, and some people are lucky, like Jonathan was lucky to have Anna, who is his advocate even today. She knows that I'm here and that I spoke to all of you about it, and she's incredibly grateful. And Anna is a wonderful advocate, but absolutely, more advocacy and understanding is always a good thing.
Any other final comment or question that came through the Twitter sphere?
It was discussed how to manage pain in sickle cell patients, because they do differ from chronic pain patients. And there were very specific questions on which drugs to use preferably.
Yes. The guidelines are IV opioid pain medicines. There are other medications that you can consider using as well. In some patients, like ketorolac would be one to consider. Ketamine would be an interesting choice as well. But you also have to remember that they're on such high doses of opioids at baseline, and so you definitely don't want to give them any less or something in place of that, because you also don't want them to withdraw.